Chapter 11, General and Local Anesthetics. Anesthetics are drugs that depress the central nervous system. We have a depression of consciousness, a loss of responsiveness to sensory stimulation, including pain, and muscle relaxation. General anesthetics are drugs that induce a state in which the CNS is altered to produce varying degrees of pain relief, depression of consciousness, skeletal muscle relaxation, and reflex reduction. There is also inhalation anesthetics, volatile liquids or gases that are vaporized in oxygen and inhaled. We also have parenteral anesthetics that are administered intravenously. Parenteral anesthetics are used to induce or maintain general anesthesia, to induce amnesia, and as an adjunct to inhalation type of anesthetics. Adverse effects. General anesthesics interactions. We have antihypertensives, so you are at an increased hypotensive effect if you have antihypertensives on board as well. Beta blockers increase myocardial depression. Oppressor Dex is an alpha-2 adrenergic receptor agonist. It is dose-dependent sedation, decreased anxiety, and analgesia without respiratory depression. We use this for procedural sedation surgeries of short duration. It has a short half-life and the patient awakens quickly upon withdrawal of the drug. Sedation of mechanically ventilated patients in the ICU is a common scenario for this use of this drug. Ketamine, we use this intravenously for both general anesthesia and moderate sedation. It does have a rapid onset of action, a low incidence of reduction of cardiovascular, respiratory, and bowel function. Adverse effects include disturbing psychomimic effects, including hallucinations. It is decreased by adding some benzos. We do have a contraindication in confusion, delirium, hallucinations, and schizophrenia. Also, if we have a person that has a head injury or has the potential or does have an increase of ICP. What is ICP? That is intracranial pressure. Alcoholism, alcohol intoxication, severe uncontrolled hypertension or heart failure, and decreased lung function. Nitrous oxide is what we call laughing gas. It's only inhaled gas currently used as a general anesthetic. Weakest of the general anesthetics. It's used primarily for dental procedures or as a supplement to other more potent anesthetics. Propofol is parenteral general anesthetic. It's used for the induction and the maintenance of general anesthesia. It is sedation. We often use this for sedation for venting our patients in the ICU. Lower doses have a sedative hypnotic effect for moderate sedation. We do have to monitor the triglycerides if it's administered with TPN or total parenteral nutrition. Adjunct drugs. We have sedative hypnotics. So those include barbiturates like pentobarbital or secobarbital. Benzodiazepines, this is what I was referring to earlier as our quote-unquote benzos. Those include diazepam, midazolam, We also have hydroxyzine, promethazine, and then you have your opioid analgesics like fentanyl. I know you all have heard of fentanyl lately. It's on the street and it's a whole bunch of places where it does not belong right now. So we have fentanyl, meroperidine, very popular, and morphine. Neuromuscular blocking drugs, or NMBDs, are depolarizing drugs, which is this, I can never say this, we just call this in the emergency room SUCS, S-U-C-C, SUCS. We're going to use that when we are going to intubate a patient. Non-polarizing drugs like pancuronium and vecuronium. Those are the two most popular I see. Anticholinergics like atropine, glycopyrrolate, and scopolamine. Scopolamine is very, very common. Scopolamine. Indications. So general anesthetics are used during surgical procedures to produce unconsciousness, skeletal muscular relaxation, visceral smooth muscle relaxation. They have a rapid onset. They are quickly metabolized. They are also used in electroconvulsive therapy treatments for depression. Adverse effects do vary according to dosage and drug used. Sites primarily affected are the heart, peripheral circulation, liver, kidneys, and respiratory tract. Big concern is myocardial depression. Another big concern that you need to associate with anesthetics is malignant hyperthermia. It occurs during or after general anesthesia or the use of SUCS. One way to prevent malignant hyperthermia from occurring is doing a full history and family history prior to surgery. So important. Sudden elevation in the body temperature is going to be greater than 104 degrees Fahrenheit. Vital sign monitoring after a procedure is so important. You're also going to see the patient is going to be breathing very quickly. Their heartbeat is going to be elevated, so elevated respirations, elevated heart rate. You are going to potentially see muscle rigidity. It is a life-threatening emergency. The treatment for malignant hypothermia is dantrolene, which is a skeletal muscle relaxant. Remember malignant hyperthermia. Moderate sedation is also called conscious sedation. It's a procedural sedation. It's a combination of an IV benzo and an opioid analgesic. Anxiety and sensitivity to pain are reduced and the patient cannot recall the procedure. Preserves the patient's ability to maintain their own airway and to respond to verbal commands. We often use conscious sedations in the ED when the docs need to set a bone, like say somebody broke their ankle, we will consciously sedate them so they can have the ankle set, or if their shoulder's dislocated and they need to pop it back in, we may do a conscious sedation depending on the severity. Local anesthetics, also called regional anesthetics, are used to render a specific portion of the body insensitive to pain and interfere with nerve impulse transmission. We have topicals, which include creams, solutions, ointments, gels, ophthalmic drops, lozenges, and suppositories. And then you have your parenteral, which are injected IV or into the CNS by various spinal injection techniques. They do not cause loss of consciousness. Types of local anesthesia include spinal or intraspinal. Infiltration, so we do an injection of lidocaine. We could do a nerve block or a topical, which is something like a transdermal lidocaine, emla cream, which is a mixture of lidocaine 2.5% and prilocaine, which is 2.5%. Indications include local anesthetics are used for surgical, dental, and diagnostic procedures, treatment of certain types of chronic pain. Spinal anesthesia is to control pain during surgical procedures and childbirth. That's where we hear the most about spinal anesthesia, right? Local anesthetics are given by infiltration anesthesia and nerve block anesthesia. Spinal headache, quote unquote. So 70% of patients who either experience inadvertent dural puncture during epidural anesthesia or undergo intrathecal anesthesia. It's usually self-limiting. Treatment includes bed rest, analgesics, caffeine, and a blood patch. This is an adverse effect to our spinals. Infiltration anesthesia is minor surgical and dental procedures, injection of the anesthetic solution intradermally, sub-Q, or submucosally across the path of nerves, supplying the target area. May be given in a circular pattern around the operative area. If we add epinephrine is a vasoconstrictor, so we would add it to reduce local blood loss during the procedure. Nerve block anesthesia is used for surgical, dental, or diagnostic procedures. Therapeutic management of pain, the anesthetic drug is injected directly into or around the nerve trunks or nerve ganglia that supply the area to be numbed. Neuromuscular blocking drugs, which are also known as what? NMBDs, prevent nerve transmission in certain muscles, resulting in muscle paralysis. They are used with anesthetics during surgery. Artificial mechanical ventilation is required, and it does paralyze respiratory and skeletal muscles. Depolarizing drugs like SUX works similarly to neurotransmitter acetylcholine, causing depolarization. Metabolism is slower than neurotransmitter acetylcholine, so as long as SUX is present, repolarization cannot occur. So what is the result of that? Flaccid muscle paralysis. Neuromuscular blocking drugs, they are the first sensation is going to be muscle weakness, followed by total flaccid paralysis. Small, rapidly moving muscles affected first, like the fingers and the eyes, then the limbs, then the neck, then the trunk. Finally, intercostal muscles and diaphragm is affected, resulting in cessation of respirations. Recovery of muscular activity usually occurs in reverse order. So smaller muscles are paralyzed first. Just think of it that way. The smaller muscles are paralyzed first, so you go from small to big. When the muscular activity recovers, it's going to go from big to small.